Hello, and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, Occupational Mix Survey, Prepare to Complete in 2023. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and now I would like to turn it over to Glenn Bunting, Director here at Moss Adams, to get us started. Glenn, the floor is yours.
All right, thank you, Amy, and welcome everyone to our presentation. For purposes of introduction, I'm Glenn Bunting, a Managing Director here at Moss Adams, and joining me today on today's presentation is Todd Schroeder, Director, and David Villagomez, Senior Manager. This year, we are extending our annual wage index focus towards the upcoming calendar year 2022 Occupational Mix Survey, or the OMS, as it's known. The OMS is a CMS-required filing that occurs by law every 3 years. With that being said, our presentation will cover the following topics applicable to the OMS filing. Todd Schroeder will kick us off by leading you through the occupational mix adjustment, including the technical aspects related to key data elements and the CMS OMS instructions. I will then discuss the current period calendar year 2019 OMS data, which will be applied for the final time in the upcoming 2024 IPPS final rule. I'll also provide you with thoughts, tips, tricks to consider with respect to the upcoming calendar year 2022 OMS filing, which is due on June 30th this year. And then finally, we'll pass the torch to David Villagomez of our team. He'll provide you with a wage index update in advance of the 2024 IPPS preliminary rule that we anticipate will be released next month, April 2023. And then David will provide a refresher on anticipated and upcoming changes to core-based statistical areas that CMS has indicated will become effective on or around June of this year, 2023. So without further delay, I'm going to turn it over to Todd. Todd?
Oh, thanks, Glenn. I'm going to start off today and mention that the guidance given today is based on the CMS instructions, which were recently published on the CMS website. Everyone remembers the most recent submission was calendar year 2019, which was due in July 2020 and submitted in August 2020 based upon the public health emergency, which allowed for an extension of 30 days. The Occupational Mix Survey is required under the Benefits Improvement and Protection Act of 2000, BIPA, BIPA was a federal law enacted by Congress that restored $11 billion in funding to hospitals over 5 years, but also requires CMS to collect data every 3 years on the occupational mix of employees for each short-term acute care hospital participating in the Medicare program. The overall purpose is to control the impact of the wage survey because of differences in management choices for staffing by types of nurses, RNs, LPNs, and aides. For example, hospitals may choose to employ different combinations of registered nurses, licensed practical nurses, and nursing aides, as well as medical assistants for the purpose of providing nursing care to their patients. The varying labor costs associated with these choices reflect hospital management decisions rather than the geographical differences in the cost of labor. The original intent was to shift dollars from urban hospitals to small rural communities. Rural hospitals advocated that they were unfairly being penalized by receiving lower Medicare payments for using a lower mix of skilled labor. In response to these concerns, beginning in federal fiscal year 2005, CMS began phasing in the occupational mix adjustment to 1, standardize the nursing skill across the core base statistical areas, or CBSAs, and 2, to adjust the wage index to only reflect the price difference between the CBSA and the national average. In federal fiscal year 2005 and 2006, the occupational mix adjustment factor was being phased in and only applied at 10% of the potential adjustment. Then, as a result of the Bellevue Hospital versus Levitt case, a court ordered CMS to begin applying the full occupational mix factor starting in federal fiscal year 2007. The actual outcome was not as anticipated. It was anticipated that the occupational mix adjustment would, 1, increase payment to providers with a less expensive occupational mix, rural providers, and decrease Medicare payments to providers with a more expensive occupational mix, or urban providers. However, the occupational mix adjustment outcome was not as accurate as anticipated because smaller rural hospitals have a minimal impact to the calculated wage index, and the occupational mix adjustment is only applied to specific occupational mix groups, which may account for less than half of all hospital salaries. We should also note, as part of the background on the Occupational Mix Survey, it is only applied to the inpatient and outpatient services. Other providers such as SNFs, rehabs, or home health agencies that use the wage index factors for their payment purposes do not receive the Occupational Mix Survey adjustment. The Occupational Mix Survey for calendar year 2022 is shown on the slide. We are in the current phase in which we compile and report the data before July 1st, 2023. The next phase will be corrections if they are needed before September 30th, and we anticipate the MACs will perform their reviews from September to November 15th, as the public use file is released by January 31st, 2024. The calendar year 2022 occupational mix adjustment factor will be applied to the federal fiscal year 2025 IPPS wage index factors, which will be used to make hospital payments on and after October 1st, 2024. The occupational mix data is collected every 3 years and is only applicable to hospitals paid under IPPS. The data collected by the Medicare administrative contractors will be used in setting the occupational mix adjustment factor for the wage index for federal fiscal years 2025, 2026, and 2027. The occupational mix has several key data attributes. Again, it will impact the federal fiscal years 2025 through 2027. The data is based upon payroll data for an entire calendar year. The 2022 survey is based upon calendar year 2022, which runs from January 1st through December 31st, 2022, and the payroll periods ending between these dates. The data is not an accrual basis, but rather a cash basis, and the pay period begin and end dates are important. It is based upon paid salary and hours for specific types of job categories. This includes RNs, LPNs, LVNs, surgical techs, nursing assistants, and orderlies. These are sometimes called patient transporters, and the final one, medical assistants. The data will also need to include the contract labor for the nurses by job categories reported in the survey. All other occupations and job categories are generally reported but are not included in the development of the occupational mix adjustment factor, which is applied to the area wage index factor. The data for nursing salaries and hours are reported for designated cost centers, which are counted in the survey. We will go into more detail on another slide, but one example would be if there is nursing personnel in a therapy cost center, physical therapy worksheet line 65 or speech therapy line 68, the nursing salaries and hours are not reported as nursing, but rather as all other category. Also similar to the wage index, the non-IPPS areas of the hospital are excluded from the survey, and therefore nursing personnel in the SNF, for example, are excluded. The CMS instructions, as noted earlier, will be recorded on Form CMS 10079, and it is as it was in prior submissions, and the data must be submitted before July 1st, 2023. The completed occupational mix survey must be submitted to the MAC, not directly to CMS, on the Excel reporting form via email as an attachment. With the end of the public health emergency announcement, we do not anticipate any delays or extensions at this time. Again, the survey will collect payroll data for a 12-month period. This is a pay periods between January and December 31st of 2022 and applied to the 2025 wage index. The CMS instructions have specific payroll begin dates and end dates. Specifically, the survey's begin date cannot be earlier than December 17th, 2021, and the survey's end date cannot be later than December 31st, 2022. Everyone should pay close attention to the begin date and end date to ensure proper reporting and compliance with the CMS regulations. During the review of calendar year 2019 data, the MAC had several follow-up questions during the review to ensure the data reported follow the CMS instructions. The survey needs to be completed for any hospital subject to the IPPS payment system, or any hospital that would be subject to IPPS if not granted a waiver. However, there are a few exceptions. These include critical access hospitals or hospitals that are no or low utilization, and hospitals that may have terminated their participation before calendar year 2022 or do not have 11 months of data to report. According to CMS instructions, hospitals need to ensure the data reported can be verified through supporting documentation. Generally, the MAC will request the underlying data used to complete the occupational mix survey. The survey will be an Excel version, which is available on the CMS website along with the instructions. We recommend having the employee level detail to include job description and payroll earnings codes. The MAC will need a paid hours payroll report or monthly trend report. The types of hours included in the survey follow the exact same rules as the wage index survey, which outline holiday, sick leave, vacation, paid time off, severance pay costs, and associated hours must be included in the survey. Hours accumulated in the payroll system to accurately pay employees for shift differential are not counted, but the salary expense is included. We should also remember from the 2019 occupational mix, if there were any adjustments to hours or salaries by the MAC, they should be reviewed and incorporated into the calendar year 2022 survey as appropriate. The survey data must include all employees that are full-time, part-time, directly hired, or under contract. The contract labor data also follows the wage index instructions, where the contract labor cannot include equipment, supplies, or travel expenses. The survey does not include employees in the excluded areas of the IPPS via worksheet S3 Part 2, lines 9 and 10, for example, the SNF, the psych, or rehab units. The survey will also exclude data for employees whose services are excluded from the IPPS, such as physician Part B and interns and residents. If a provider has a home office or related organization, employees are allocated to the employees are allocated to the IPPS reimbursable cost centers and outpatient departments of the hospital. These are included in the survey and must be reported in the appropriate category. If the home office personnel are only providing administrative services, their wages and hours are included in the all other category. Again, according to the CMS instructions, there are specific cost centers reported in the Occupational Mix Survey to accumulate nursing hours. These include, for example, nursing admin, adults and peds, recovery, clinics, the ER. If there are nursing personnel in other cost center lines not listed, their salary and hours will be reported in the all other category. For example, again, if there were RNs working in the radiology department, the salary and hours will be all other. These nursing salaries and hours are not utilized in the survey or the development of the Occupational Mix Survey adjustment factor. We'll now walk through the categories of the Occupational Mix Survey instructions. First, we have registered nurses. These registered nurses assess patient health problems and needs and develop and implement nursing care plans and maintain medical records. This is generally nurses that provide direct patient care. This should not include nurses that are only in administrative or leadership roles. The second category is the LPNs or LVNs. They care for the ill, injured patients in the hospital. Surgical techs assist in the operation and may help set up the operating room, pass instruments and other supplies to the surgeon or surgeon's assistants. Category 3 is nursing assistants. They provide basic patient care under the direction of nursing staff. They perform such duties as feeding, bathing, dressing, or grooming patients. Orderlies, which we earlier recognized as patient transporters, transport patients to areas of the hospital, such as the operating room, using wheelchairs, stretchers, or movable beds. The fourth category is medical assistants. Medical assistants perform administrative and certain clinical duties under the direction of physicians. Their administrative duties may include scheduling appointments, maintaining medical records, billing and coding information for insurance purposes. Their clinical duties may include taking and recording vital signs, medical histories, or preparing the patient for an examination. In this category, do not include health information management personnel, medical secretaries, ward clerks, or general office personnel. The fifth category is the all other occupations. This is considered all non-nursing employees in the IPPS reimbursable cost centers and outpatient departments that are included in the wage index. This category would include the wages and hours of nurses that function solely in administrative or leadership roles and do not provide direct patient care themselves. However, this category must not include occupations that are excluded from the wage index, such as physician Part B services and interns and residents. This category would also include the home office personnel that perform administrative functions or work in IPPS cost centers in outpatient departments that are included in the wage index. Let's talk about the CMS instructions around paid salaries and paid hours. Paid salaries, the Occupational Mix Survey is to only report salaries and wages. We do not include fringe benefits or wage-related costs, which are reported on the wage index survey portion of the cost report. The provider reimbursement manual provides guidance in not including these items. The paid salaries should again follow the wage index rules and include total paid wages and salaries, including overtime, vacation, holiday, sick, lunch, and other paid time off, severances, and bonuses. Paid hours should only include regular hours, overtime hours, paid holiday, vacation, sick, and other paid time off hours, and hours associated with severance pay. The survey does not include non-paid lunch periods or on-call hours in the total paid hours. We again stress the paid hour definition matches the rules for counting hours consistent with the wage index survey. We need to ensure the process to count the overtime hours along with the overtime pay is calculated to only count 1 hour when an employee is paid time and a half or double time, depending on the hospital's human resource policy. Employees that are considered exempt and paid a fixed rate must be recorded based on a 40-hour per week or the number of hours in the hospital standard work week. Many hospital payroll systems generate or accumulate hours for shift differential or other special pay conditions such as preceptor or night shift. These payroll hours are not included in the wage index or occupational mix survey, as they are an internal function of the payroll process to ensure the employee is paid correctly, but do not count as a worked hour. The total pay for these items are included, just not the hours. And Amy, it looks like we're up to our first polling question.
All right, thank you. So the first polling question is, how would you rate your comfort level in preparing the survey this year? A, very comfortable, B, somewhat comfortable, C, not comfortable, or D, unsure or not applicable. And the polling questions are located on the slides that we're presenting, and we'll give you a few minutes to respond here. You're going to click the button next to the answer you choose and hit submit. And I do see some responses coming in through the Q&A window. If you want to receive CPE, you need to respond on the slide itself so it can track for you. All right, we'll do another 5 seconds. Okay, here are the results.
Oh, thanks, Amy. Well, it looks like we have people in all categories almost to the same level of degree of comfortable and somewhat comfortable. So I'm glad everyone joined today, and hopefully we can provide you some guidance or information. And at this point, I will turn it over to Glenn, and he'll talk through the next sections.
All right. Thank you, Todd. In this section, I want to spend some time on the current Occupational Mix Survey. We're getting to the end of that life of that survey, and it's important to understand, where are we with that survey? Where did we land? So to begin, the current Occupational Mix Survey is based upon calendar year 2019 data, and it was submitted to CMS initially during calendar year 2020. The 2019 OMS is used for the Medicare IPPS payment rate setting process for federal fiscal years 2022, 2023, and 2024. It's also important to realize that the 2019 OMS data was comprised of pre-pandemic data. In the most recent public use file released by CMS on or about January 27th of this year, there were the following hospital statistics. There were 3,070 IPPS hospitals eligible to be reported in the OMS data. And of this amount, CMS accepted approximately 98% of this data, or 3,007 hospitals. But there was about a 2% rejection rate related to 63 IPPS hospitals. These hospitals with the rejection of the OMS data were omitted from the Medicare rate setting process because their wage index data was considered to be, in simple terms, just outliers. Thus, the OMS data itself was not considered to be out of tolerance, but instead it's being excluded because of outlier data associated with the wage index information. Just for simplicity, the OMS data is linked together with the wage index information that is reported annually. One additional point of clarification is the OMS data can be changed each year. A lot of folks don't know that. So understandably, the OMS data changes the most during year one. Typically, right after you report it, it's typically corrected or can be corrected. And then when you get to years 2 and 3, the OMS data tends to change very little. So how does the 2019 OMS data look at this point in time? So in this slide are the official raw average hourly rates for each of the nursing categories. Generally speaking, the 2019 survey, as compared to the previous 2016 survey, shows an increase of 6 to 9% in nursing salaries over this 3-year period. These values have not increased substantially over the last 2 years. However, with the pandemic and the surge in nursing rates, I expect the 2022 OMS will show double-digit increases on a percentage basis. What do these values represent in the overall scheme of the OMA calculation? If we focus let's just focus on the RN and LVN categories. In the calculation of the OMA, the use of more registered nurses or registered nursing at $44.43 per hour versus LVNs at $26.90 per hour will ultimately drive up the nursing component of the OMA and will lead to a more negative OMA adjustment. This means lower Medicare reimbursement. However, the opposite is also true. If a hospital uses a low ratio of registered nurses as compared to all of its nursing, this will drive down the nursing component in the OMA and will lead to a more positive OMA adjustment. That means higher Medicare reimbursement, all things being equal. On this slide, what we did is we isolated the top 10 CBSAs with the lowest OMA factor. These are the CBSAs that are experiencing the worst adjustments from the Occupational Mix Survey that's currently in play. We note there are several CBSAs that are located in California on this list. Just for general knowledge, hospitals that are in California are required to follow mandatory nurse-to-patient staffing ratios, which have an unfavorable outcome in the OMA calculation. The state of Hawaii's rural hospitals, with their high cost of living, also receive an unfavorable OMA, likely due to greater use of traveling nurses and such with high cost average hourly rates. There's a couple of hospitals on this list, such as rural Nevada and rural Wyoming, that receive certain Medicare payment protections given their status as status as frontier states. We expect the greater use of traveling nurses with high cost average hourly rates is driving the low OMA ratios for these two areas, but at the end of the day, their frontier state status protects them. It's worthwhile to kind of dissect these ratios down a little further. So on the next slide, we're going to analyze the CBSA with the lowest OMA adjustment ratio, and that's the San Luis Obispo CBSA. So upon review of this CBSA, the reported data appears to be skewed towards using higher registered nursing personnel than lower options such as nursing assistants and medical assistants. This is likely due, in part, as I mentioned, the mandatory nurse-to-patient staffing ratios implemented by the state of California. However, it could also be due to incorrect reporting. So note the reported average hourly wage for medical assistants is at $8.77 per hour, which in truth is less than the minimum wage. Thus, while it's easiest to point at the state of California's mandatory nursing ratios as the catalyst for low OMA adjustment, one must also look at the raw data being reported and make a determination as to whether it properly reflects your operations. In this case, it's pretty clear that there's something wrong with the medical assistance category at an average hourly rate of $8.77. The MAC did not catch this upon review, and in truth, we shouldn't expect the MAC to identify all data errors. Probably the question that should have been asked but wasn't was whether these average hourly rates for the nursing categories are reflective of your operations. If you can answer this question in the affirmative, you can be assured your reported data is at least reasonably stated. The good news is, looking forward, or I should say the not so good news is, looking forward, the San Luis Obispo CBSA is stuck at a OMA adjustment factor of 0.8938. for the upcoming federal fiscal year 2024 IPPS. But the good news is on a go-forward basis, they have the opportunity to reset their OMA in the upcoming 2022 OMS. We're going to look at the top 10 CBSAs with the highest OMA factors. On this slide, we've isolated those CBSAs that are currently experiencing the highest adjustments from the Occupational Mix Survey. Many of the locations on this list are located in small urban communities where the ratio of using registered nursing is less than the national average. These communities limit the use of registered nursing, and therefore they are rewarded for this practice through the OMS, and they receive a larger Medicare payment than their peer CBSAs. Interestingly, the CBSA with the highest OMA adjustment is Madera, and Madera is located in the state of California. So given the existence of California's mandatory nurse-to-patient staffing ratios, it is kind of surprising to see a California CBSA leading the OMA. So let's unpack Madera's CBSA's OMA adjustments. So as you can see here, I think I was off by a slide. As you can see, Madera's registered nursing average hourly rate is more than the national average, but arguably lower than other hospitals in the state of California. We also find the other nursing average hourly rates are on the low end of the spectrum as compared to other facilities in the state of California. So it's plausible this CBSA is not counting their OMS paid hours in a manner that's similar to the counting of these same hours in their wage index data. We also suspect in order to arrive at the highest OMA adjustment, the hospitals in Madera CBSA could conceivably be reporting more lower cost nursing and less higher cost nursing in their OMS. In other words, that they have a heavier mix of nursing assistants than say RNs. It'll be interesting to see where the Madera CBSA lands in terms of the OMA and the upcoming 2022 OMS reporting. So what are some takeaways from the current survey? Overall, in 2019, in that survey and what's currently being applied, the total nursing salaries increased 2.23% per year. What will the 2022 OMS yield? I'm expecting total nursing salaries will have increased substantially in the upcoming survey. It's an important point is hospitals that report OMS information that is not accepted by the MAC receive the average OMS data from all other hospitals in their CBSA. This means those hospitals no longer control their own destiny. They are receiving an OMA adjusted wage index factor that's been developed by their peers. This could be beneficial or it could be detrimental to your Medicare payment calculation. The 2019 OMS is largely final at this point, but there could be small incremental adjustments made to the data between now and when the final IPPS rule is issued in early August. And then finally, like I mentioned, the OMS is open to revision if needed each year. Again, most revisions happen in year one, but additional revisions can happen in years 2 and 3. So let's pivot to a discussion on the 2022 Occupational Mix Survey. What lessons have we learned and what can we apply so that we're reporting our data in a better manner? So to begin with, your OMSA data compilations and drafts, you need to get those done early. For the payroll data, what we recommend is to adhere strictly to the CMS reporting instructions. Don't make assumptions or presumptions about whether job titles should or should not be included in the nursing categories. I think this is one area where there are large mistakes that are made. CMS lays out in their reporting instructions the types of categories that should be reported. Don't make presumptions that you should include more than what's just there. Also ensure your payroll data includes a full year, 26 or if necessary, 27 pay periods of data. You need to report the OMS data in the same manner as you follow for the reporting of wage index information in your filed Medicare cost report. It should be very, very consistent and similar. Only report the payroll data associated with the cost center line numbers that are laid out in the CMS reporting instructions. Todd had a slide on this earlier. And then in terms of like home office, related organizations, general service overhead, expense allocations, those all do need to be accounted for in your OMS filing. In terms of contract labor, again, just adhere strictly to the CMS reporting instructions. Be sure and report all contract labor activity in the OMS, not just nursing contract labor. Report your contract labor for nursing in a similar manner as you report that nursing personnel that are on the payroll. You need to be consistent in your reporting between your payroll records and your contract labor. And probably a big one is don't ignore contracted non-nursing personnel in the OMS. Believe it or not, reporting contracted non-nursing personnel will actually drive up your OMA and your Medicare payments. As Todd indicated earlier, excluded area contract nursing costs are not to be reported in the OMS. And probably the biggest item here is allow for sufficient time to document contract labor so your data at the end of the day can survive an audit. It's audit proof. The payroll portion of the OMS will be quicker to complete than the contract labor portion. So keep this fact in mind as you proceed through the OMS. Then more filing pointers. Once the OMS data is gathered, compiled, and in a draft form, I would consider the following. I would suggest that you have an expert with knowledge of OMS conduct a pre-filing review. This is especially important as the slightest misstep in the OMS could potentially cost an organization millions of dollars in lost Medicare reimbursement over the course of the 3-year period that the survey is applicable to. Compare the results of your 2022 Occupational Mix Survey to the final 2019 OMS data that was released in the CMS PUF file. Does the average hourly wage by nursing category look comparable to the same data from 3 years prior? Does the average hourly wage by nursing category look comparable to your peers? What about the mix of nursing, the RNs, LVNs, aides, and medical assistants? Does that look consistent with what you know of your hospital operations? I think that's a big key there. Another item to consider is how has the COVID-19 pandemic altered your 2022 results as compared to 3 years prior? Do you have documentation supporting these variances in the average nursing hourly wage, and have the dollars and hours by nursing and non-nursing category substantially changed? And then finally, has the percentage of reported nursing to total personnel costs changed substantially over the 3 years prior? There's really just lots of analytics and questions that one needs to apply before sending in and submitting your occupational mix survey. And then finally, we have a slide here that are commonly asked questions. What happens if I don't report my OMS by it's now due June 30th, 2023? And the answer is you can use the wage index correction period to request a correction to the OMS data that you were supposed to file with the MAC. The wage index correction period closes on September 1st of each year, so if you fail to request a correction by September 1st, what's going to happen then is the MAC will seek this information from you during their review of the federal fiscal year 2025 wage index data. So there's different entry points along the way in terms of getting your occupational mix survey in. What happens if you don't respond to the MAC's request for OMS data? And then what happens is at the end of the day, if you have no OMS data reported, you've lost a little bit of control on your Medicare payment rates. You'll receive the average of the OMS data within your own CBSA, and like I mentioned earlier, this can be beneficial, could be detrimental. It just depends how everybody else reports. And then if you find errors in your reported OMS data, what steps can you take to correct the OMS? The answer is you must use the wage index correction window to request changes to the OMS. This can occur, again, anytime during the 3-year period. Most of those changes happen in year 1, but you rest assured you can change your OMS data in years 2 and 3. So with that, we're going to move on to a wage index update for fiscal year 2024. But I think before I turn it over to David, we have another polling question. So I'll give it to Amy first.
All right, thank you. So our second polling question is, do you routinely monitor your wage index information to ensure it is properly stated and perform annual analysis to identify opportunities? Yes, no, unsure, or not applicable. And then I also want to acknowledge we do have quite a few questions coming in and a lot of content to get through. So if we don't have time to respond during the webcast, we will do our best to follow up with you. All right, here are the results.
Okay, so most of the are yes. That is good. Good afternoon, everyone. I'll be covering a little history and updates for the fiscal year 2024 wage index. The Social Security Act defines the adjustment factor, which is the wage index, as part of determining the prospective payments to hospitals. CMS currently defines hospital geographical areas based on the definitions of core-based statistical areas established by the Office of Management and Budget, which is the OMB. The wage index also reflects the geographical reclassifications of hospitals to other major markets. The wage index factor is developed. CMS is required to update the wage index annually based on wage-related costs derived from the Medicare cost report, occupational mix surveys, payroll records, contracts, and other related documentation. CMS then derives an average hourly wage for each labor market area and the national average hourly wage as well. Current use of the Medicare area wage index data. The adjusted area wage index is currently used in the IPPS, OPPS, and California Medi-Cal fee-for-service ARP ERG systems. The unadjusted area wage index is used in the skilled nursing, rehab, psych, and other Medicare payment systems. Many hospitals factor in the adjusted wage index in the respective Medicare Advantage and Medi-Cal managed care contracts in their rate-setting process. Also, please note that the adjusted area wage index accounts for geographical reclasses, rural, war, budget, neutrality, and OCMIX as well. And as you can see here is an example of the DRG operating capital payment calculations using wage index factor and geographic adjustment factors. Medicare wage index salaries. The wage index salaries flow from worksheet A, column 1 to S3, which come from your respective general ledger and include directly paid and accrued salaries, PTO, holiday, severance, and bonus pay. Please note, capitalized labor costs are generally not included in the wage index data. Here's an example of the S3 with total salaries. Medicare Wage Index paid hours. The source for paid hours is the respective payroll report. These hours only include hours expensed within the current fiscal year cost reporting period and not accrued hours. The payroll data will include actual hours worked and non-productive hours, and these hours will be reported on S3 Column 2 as well. The payroll data will also include budgetary statistics, such as, but not limited to, bonus pay, differential shift hours, hours related to benefits, or on-call. Please note budgetary stats are not included on the S3. Here's an example of the S3 for the hours as well. Contract labor. Only contract labor from your respective trial balance can be reported for the wage index. If wage costs and hours are not clearly identified within the contract, other supporting documentation will be required, such as invoices. Contract labor is reported on the following lines for the S3. Line 11, which is direct patient care. Line 13 is medical director fees and hours. And line 28 is any admin, legal, tax, consulting costs and hours. Here's an illustration of where contract labor is inputted on the cost report. Benefits. Benefits expenses are reported on Worksheet S3 Part 4, which includes the following: retirement plan, admin and legal, health insurance, taxes paid, and others, such as daycare tuition. And here's the illustration of Worksheet S3 Part 4 where the benefits are inputted. Rule 4 considerations. Wage index applied to urban hospitals in the state cannot be lower than the rural wage index for that respective state. This is the rule 4 provision. CMS must apply the rule 4 in a manner that is budget neutral on a national level, which means that for any increases in wage index for hospitals based on getting the rule 4, CMS must lower wage indexes nationally by applying a rule 4 budget neutrality factor. Medicare geographical reclassification. CMS provides an avenue for hospitals to adjust their respective area wage index, and below are the 3 most common scenarios. A hospital reclassed to another rural or urban area. All hospitals in a rural county reclassified to an urban area. All hospitals in an urban county reclassified to another urban area. Hospitals must submit an application to reclassify via CMS by the annual September deadline, and once approved, its new status is good for 3 years. Approximately 35.6% of all hospitals nationwide received a Medicare payment that was not based upon their geographical area in the fiscal year 2023 IPPS rule. In recent years, CMS has noticed a downward spiral for hospitals related to wage index, meaning hospitals in a high wage index area can afford to pay higher wages, which allows them to continue in a higher wage index area. And all hospitals in a lower wage index are forced to cut costs, which lower their future wage index. To help address this disparity, CMS took the following actions. Increase the wage index values for certain hospitals with low wage index values by applying a uniform budget neutral adjustment to the standardized amount. Change the calculation of the Rule 4 for rural reclass hospitals and provided for a transition for hospitals that will experience comparatively significant decreases in their wage index values in a budget neutral manner. This policy change impacted the calculations of Rule 4s in several states, including Arizona, California, Connecticut, Florida, Hawaii, and Massachusetts. Now I'll turn this over to Amy for the Q&A.
All right, thank you. So our third polling question is, do you regularly model the financial impact your wage index factor has on non-hospital payments other than Medicare inpatient and outpatient? A, yes, B, no, C, sometimes, or D, unsure. And while you're responding, for those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handouts. And then we're also sending them via email tomorrow along with a recording of this webcast.
So Amy, I was going to take this opportunity to sneak in a response to one of the questions and it's a pretty common one. It states, what about charge nurses that provide both direct care floor duties and supervisory duties? This is a common issue with completing the OMS, and the best response I can give you on this is that you are supposed to have some sort of a mechanism in terms of tracking time to separate between patient care and non-patient care. So it is something that we do encounter every OMS filing cycle.
All right, and I'm going to pull up the results here.
Okay, so it looks like most of the polling questions are unsure. Okay, I'm going to be discussing upcoming changes to the core-based statistical areas, CBSAs. Office of Management and Budget, OMB background. This program has been around for about 70 years for finding statistical data. Standard metropolitan areas were first used in the 1950 census publications. Shortly thereafter, the micropolitan areas were developed. CBSAs are defined by county size and the following current delineations. Please see below. Metro is about population 50,000 or higher. The micro is about population between 10,000 to 49,999. And counties with populations in less than 10,000 are termed outside core-based statistical area. In 2018, the OMB tasked the community to review the 2010 metropolitan and micropolitan area standards and provide recommendations by December 2020. And then on January 19, 2021, that committee had the following recommendations to the OMB below. Three of the ones that are highlighted are the minimum urban area population to qualify in metropolitan statistical area should be increased from 50,000 to 100,000. OMB should make publicly available a schedule for updates to the core-based statistical areas, and an OMB should continue the use of American Community Survey community data and the measurement of inter-county connectivity through the changing of socio and economic trends may warrant considering changes in the 2030 standards. And then under the recommendations of the committee, OMB would release 3 different types of updates. You have your annual update, your 5-year update, which is the more broader update, and then decennial delineation update, which includes the 5-year update and plus the qualification of central counties. And below is the update type and expected release date. And as you can see, the decennial delineation is expected to be June of 2023 this year. And I'll turn it over to Amy for the next question.
All right, thank you. The last polling question is, were you aware CMS was considering a change to the current configuration of core-based statistical areas? A yes, B no, or C unsure. And then once you've completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window.
And then again, Amy, I'll take another stab at taking this opportunity to answer some more questions. We have a boatload of questions that have come in, but we also have a large number of our friends from the MAC that are on this webinar, and there was a comment from the MAC that and I think what it's intended here is as you go through their audit and review of your OMS data, they wanted to point out that, reasons for variances in the data from one cycle, from the 2019 OMS to the 2022 OMS. You can't just indicate out there that these variances are due to the COVID pandemic. You have to come up. I think what the intent here is you have to come up with a more detailed explanation or story as to why, say, registered nursing went up, significantly from one period to the next. I think that's the intent of their comments. So just everybody out there, keep that in mind that you may need to elaborate a little bit more when it comes to this next cycle. Again, just saying the COVID pandemic is the reason for the increase is not going to be sufficient. You need to say more. Also, somebody put a question out there about nurses. They had a nursing strike, and so perhaps they had to hire more nurses at their facility during 2022. All the nurses that you hired during 2022, whether they're on payroll or the contract, whatever the reason, they do get counted in the OMS, but do follow the OMS instructions. That's the best guidance I can give you on that front. So, Amy, I'll turn it back to you so you can show us the results.
All right, thank you. Yes, here are the results, the last polling question.
Okay, and most everyone replied with B, no. Tim, CBSA changes impact the following for governmental reimbursement: geographical wage index factors for urban and rural areas, wage index reclassifications, rural redesignations, 340B thresholds, and sole community hospital eligibility. Next steps, closing thoughts and questions. I believe Glenn has taken a couple of those on questions. Our next reimbursement webcast will be April 5th over worksheet S10, MAC audit update and future reporting. And a couple of resources I want to mention are the complementary wage index and occupational mix survey analysis. Feel free to email us to request those, and save the date for the annual healthcare conference, which will be November 1st to the 3rd, 2023 in Las Vegas at the JW Marriott Las Vegas Resort and Spa. And now we'll turn it over to Amy.
All right, yeah, so we are running up on the hour here, and so I want to thank Glenn, Todd, and David for a great presentation today. I also want to thank our audience for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer yours, we will do our best to follow up with you after the webcast. Also, feel free to reach out to our presenters if you have additional questions. Their contact information is in the slide deck as well as in your console. And if you want to set up a separate call to discuss this more in depth, please let us know by dropping a note in the Q&A window. And if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks if you have difficulty downloading it now. And finally, here's a link to an online survey for today's presentation. And thank you for joining us. Take care, everyone.